So this is a 15-year-old girl who is presently studying in a special school. So this is the clinical profile from the time she got sick to date. In 2010, when she was 10 years of age, she had a psychotic syndrome, and it was associated with many vacant stare episodes. 2011, she had micrographia, gait disturbances, slurred speech. She used to get tired very easily. End 2011, she was refusing to wear appropriate clothing with worsening of the psychosis. 2012, there was dystonic posturing of the last two fingers of both the hands. Though she did show significant improvement in language, communication, and attention with treatment. And the residual symptoms were delusions and hallucinations with odd behaviors. So when it started in the beginning, that was in 2010, multiple vacant stare episodes. She was very afraid. She was irritable. She used to mutter to herself, smile to herself. And she said she could see small people, so Lilliputian non-existent objects. And that time she was 10 years old. It was abrupt. It was progressive. And she was staying in a village at a relative's house where they had gone for a function. So the mother said possibly she didn't like what was happening. She couldn't really settle down there. And the illness worsened shortly after when the mother got sick and she was admitted in hospital, the mother in hospital for 3 days, and this girl had to stay at a friend's place. So there is a lacuna there. We have asked for history, but she I think was too young. The patient was too young to tell us what happened, and the mother doesn't seem to know. Now, detailing the history, she was well until February 2010. Like I said, they went to a family function, and there she had these stare episodes with her eyeballs deviated to one side. And 3 days later, like I said, she went and lived at a friend's place. She began expressing fearfulness. She was abusive, and she was seeing these non-existent little people while in the bathroom. And she said that she was being controlled by something in her head, possibly a transmitter. And she also felt that she was a boy. She could hear her friends talking to her and abusing her all the time. And then there were crying spells, and she felt very hopeless. And there was this suicidal gesture when she said she wanted to jump off the roof. So there was a lot of problems in all the functions. Now in early 2011, she had very rapid jerky movements of the neck, perioral region, tongue, the shoulder, frequent eye blinking, the handwriting was impaired, she was having problems with walking, speech was slurred, and then she's been having these sustained contractions of the last two fingers of both the hands. And she was investigated, there were no medical problems, there was no history of substance use, and no clear anxiety syndrome. So this is one snapshot of what happened in 2010 and 2011. Now, going on to the family history, the mother said that there was psychosis in an uncle, and he just one fine day went away and never came back. So we don't know what happened to him. And then her father was treated for pulmonary tuberculosis and tuberculosis of the spine. And this girl's developmental milestones were normal. So she was fine until 2010, except for the delayed speech. She was temperamentally quite consistent, and she attained PENARC at 13. So these are the investigations early in 2010 when the problem started. The CT was normal, followed by an MRI, which was also normal. And then the blood tests were run at the place where she was seen. So she was in Dehradun. So routine LFT, RFT, thyroid, etc. were normal. 2011, they've done a CT scan of the thorax, and they found a minimal bilateral pleural effusion. They didn't do anything for it. She was managed conservatively. An MRI of the spine and the brain were normal. And then the CSF went for virology to NIMHANS. Everything was negative. This is what they do there. Chest X-ray was normal, but the ESR was elevated, the CRP was up, and the white blood cell count was very high. And the EEG picked up encephalopathy, so it was possible infection versus inflammatory. So this is the EEG of 2011. Lot of slowing. So year 2012, again an MRI was done, which was normal. EEG picked up some seizure activity with, again, an encephalopathic pattern. The total counts are really high, 23,000. ESR is quite the same at 72, RA factor 48.5. And we did the inflammatory markers, the anti-DS, DNA, ANA, all those were negative. So 2013, we again did the total count was 13,200. Another MRI was normal. This is the EEG of 2012. So now you can see a TC of 45,000, which is really high. It was predominantly leukocytosis and with normochromic kind of anemia. ESR is again 675, CRP is gone up a little more. And the EEG, like I showed, had some seizure activity. CT scan, there was bilateral pleural effusion at that point. So she really didn't go on treatment for the first 3 months when she was sick. And then atypical antipsychotics and topiramate was started. The worsening of symptoms to 2010, poor response. And then clozapine was added in December 2010 and then built up to 300. Then we had arpizole and amisulpride and the liver protectives. So here again, olanzapine was added in 2011 along with nootropic and frisium and mineral supplements. So there you can see there was a persistence of psychotic symptoms. And then they came down to Chennai in 2011. And then we did a workup all over again. So here she was given clozapine 300, topirol with memantine, and then we worked her up for Wilson's. Though the KF ring there was no KF ring, it was negative. It was seen to slit lamp, so it was negative. So here she began to show some improvement with regards to psychotic symptoms, cognition and functioning. The odd behaviors just remained there. Clozapine was reduced from 300 to 150 and levetiracetam was introduced at 500. At this point, there was increase in self-talk. The perioral movements had increased. There was dystonic posturing of the last 2 fingers. And Dr. ESK pulled out the levetiracetam, possibly attributing these to that, and topiramate was restarted. So here we thought of an atypical Wilson's, and I'd like to show you the next slide. So these are the copper, serum copper and ceruloplasmin that was done from 2011 till 2 days back. So February 2013 it was up, the serum copper, and again after starting penicillamine, even this year in Jan it's been really high, 235.2, and at the end of Jan it's 129. And the 24-hour urinary copper has always been normal. It was done once last year and once very recently, so both are normal. Ceruloplasmin is at 53 on 10th, and the rest are quite okay. There's one towards a lower normal. So the trial of D-penicillamine was started when we found that the copper was up, and it was started at 500 a day. So we noticed some improvement in gait and self-talk when she was in penicillamine. Then it went up to 1 gram and then it was brought down to 500. And at this point, there was a break in therapy and they're exploring a lot of alternate options. So they went to a doctor who practices alternate medicine, Siddha. So she went there and she was on some medicine. So she stopped all our medication. She came back with some skin pigmentation on the chest and the back. And she came back and we restarted D-penicillamine. And then the skin condition was taken care of and she's much better now. So this is how we started from March last year, Silamine at 250 and then it increases. There was a break in 2013, like I said. And then now it's at 1 BD of 250 milligram. So we did the psychological assessments. I'll quickly take you through those reports. So pre-morbidly, she was a very good student. She liked math, science and all that. She was doing well. And now she's gone to special ed school, so she's really declined. So the assessments were done at this point, I think quite frequently, the psychological assessment. So 2010, there were no psychotic features in the personality measure. And she was moody, she was depressed, and she was overreacting to certain stimuli. Again, May 2010, mild anxiety, depressive state, low self-confidence, low self-esteem, and feels rejected in school. Parent-child relation was as it usually is, loving and caring parents, so there was nothing amiss there. 2011 assessment summary, all of this is happening. The cognition is impaired, there are behavioral problems, the movements are happening, all of that is still on. IQ assessment in 2011, she was uncooperative, it could not be done. So, however, they made an estimate of average IQ. Eye contact is poor, speech is decreased. 2012, social problems predominant, smiling to self, muttering, etc. still continue. Second half of 2012, she took a break. That's when things went really bad. She wasn't attending school. And this is when we introduced the penicillamine. And these are the improvements we noticed. In terms of gait, she was much better, but the rest of it was kind of fluctuant. This is the current review. Some improvements in behavior, but problems are there. She's actually equivalent to a grade 1 level student. So we're starting with 2-digit mathematics and things like that. And she gets very agitated when she gets hungry. So if we start an assessment around 10 o'clock, we have to see to it that she eats something every hour. Otherwise, things just go awry and then we have to just give it up and she has to come back another day. So we have to see that she's not hungry. The self-talk and the problems in emotion regulation, lot of disinhibition now, and with just age appropriate, there are things happening. And visual hallucinations. Test findings here, perceptual reasoning, working memory is all very low, severe cognitive difficulties, and verbal abilities could not be formally assessed. So she came to us for a review with Yogini, who is a psychologist. So the first half went off quite well. She was cooperative. I think she'd had a good breakfast. She came, so she was good. The second half, because she had to concentrate a lot on the tasks that were given, she just kind of withdrew and she became very restless and we had to make her sit outside. And we couldn't continue the test after that. So this is a summary of the changes. Cognitively, there's not much of a change, as you can see. There's been a quick decline, and then we are working very slowly at things improving. So not much of a change. Behaviorally, there's quite a bit of change, and the self-talk and abnormal movement are less, and aggression is less, and the outbursts are much less. And she's able to do some of her ADLs now. So this is a summary of the previous slide. And then she had problems with handwriting and gait. So the physiotherapist took care of that, and she underwent 20 days of sessions with handwriting, and then there was joint compression, positioning, etc. was done for the hand. And then we asked her to color with crayons. So she liked doing all that. She was cooperative. So outcome of this, like I said, the handwriting is much improved. If she is ready to sit at a task, that is. And there's a lot of self-talk, but she does her ADLs very much on her own, though her mother still goes in and checks that she's doing it properly. The psychological treatment was administered by Mrs. Shubha Mukund. So like I said, she was the top 5 in her class when she was smaller and she was well. So these are the techniques which were employed. Play therapy and token economy and all that. So pencil shading, a little bit of music therapy, because she always has her ears plugged and listens to music. So I don't know, she's trying to cut off the hallucinations, I don't know that, but she's very calm. If she gets restless, we just let her sit outside with her earphones on and she listens to music and settles down. But on the other hand, there are kinds of music which also irritate her. So the mother kind of takes care as to what she's listening to. So course of therapy, like I said, there were very many breaks because we used to go in search of alternate options, because I think they, like any other parent, they wanted her to get better quickly. So they did explore other options. And whenever she was in therapy and was taking medicines, we could see a consistent kind of improvement. Though it was partial, the improvements were there. So these are the breaks. Now the latest is an obsession with her neighbor's son. So there's a lot of disinhibition here, a lot of social issues because of this. So she's not allowed to come out and play when all the other kids are outside because she's disinhibited. So this is the current behavioral profile. Like I said, cognitive ability is still impaired, social skills a little better, but a lot of movements are happening as I showed to you in the video. He did a Yale Tic Severity Scale. It was 61, and the NPI was high on a lot of domains, the delusion, and then the dysphoria, the irritability, the aggression, though it's much less than before. So the significant improvements were with penicillamine up to 1 gram a day. Language and behavior was much better. And now she is attending a special school. She's able to go there and spend some 4 or 5 hours on her own. The doctor shopping, like I said, happened because they wanted quick improvement. So this is the video of Verita.
म्यूजिक अरे सुबह उठ के आपको मैथ करना था ना, टेबल्स पढ़ना था ना, आज क्यों किया टेबल्स? भूल गए। हाँ आज तो शुभांगी से नहीं मिलना था ना, इसलिए भूल। फिर क्या किया?
फिर शाम करके जल्दी से देख के आ गए।
कौन सा प्रोग्राम है?
जिमी म्यूजिक।
जिमी म्यूजिक। ये प्रेम कथा चरित्रम। अरे ना? प्रेम चरित्र कथा अरे ना? महेश बाबू थे ना? బాగుందా ఆ పాట నాకు చెప్పు, నేను తీసుకుంటాను, నా ఫోన్లో పెట్టుకుంటాను, ఆ పాట నేను పెట్టుకుంటాను, నువ్వు వస్తావు కదా నా దగ్గర, నేను ప్లే చేస్తాను. ఎలా ఉంది నీ బిస్కెట్? బాగుందా? పొద్దున ఎంత తినలేదు నువ్వు? పొద్దున ఆకలి లేదేదా? వై యు విల్ ఈట్? ఆకలి లేదు. ఈరోజు బాగుంది, ఎవ్రీథింగ్ బ్యాంక్ ఎవ్రీథింగ్ నీదేనా? మరి ఇక్కడ వచ్చేటప్పుడు వేసుకోలే ఎందుకు?
ఎప్పుడు వేసుకోలేదు,
मर्చిపోతా ఈరోజు स्कूल से छुट्टी आज भी? अरे ये तो बहुत अच्छा हो गया, डेली छुट्टी every day you on a holiday every day now. Why miss won't ask where's Virita? She won't ask where's Virita. She's asking you where is Virita? Right? If you don't go to school, she'll call Rama auntie and she'll scold her. She'll scold Rama auntie. She'll tell Rama auntie every day you're calling her to the clinic. Okay, tell me all your friends' names, Virita.
Bhanupriya.
Then Shubha. Lavanya. Mahalakshmi. 2 Mahalakshmis, huh? 1 or 2? 2. Okay, yesterday what all did you do in school? GK in school. Okay, what did you do in GK?
Body care.
Okay. What did they teach you in body care?
Only writing.
Only writing. Okay. You take your notebook, your pencil and all that to school? Okay. With whom do you sit in class?
Shubha.
Okay. What's your class teacher's name?
Renuka.
And whom do you beat in school?
Lavanya.
And which ma'am do you beat in school? Principal ma'am. Why do you beat your principal ma'am?
Okay.
తిట్టేస్తుందా? ప్రిన్సిపల్ తిట్టేస్తుందా? నువ్వు తిట్టేస్తావా? వై? ఎందుకు?
అంటే పంపిస్తుంటే కొట్టేస్తా.
अरे प्रिंसिपल मैम won't scold you? डांटती नहीं?
डांटती है।
तो क्या कैसे डांटती है? कैसे डांटती है? बाप रे, आप डरते नहीं हो उससे? डरते हो? आप किससे डरते हो? प्रिंसिपल मैम और क्लास टीचर से? ना। क्या करते हो स्कूल में? राइटिंग, रीडिंग, then games? What do you play? क्या खेलते हो आप? झूला मतलब योगा, भागना वो सब नहीं है? वो सब नहीं है स्कूल में? योगा, एक्सरसाइज सब नहीं है? तो इधर आके करोगे योगा?
हाँ।
इधर एक बहुत अच्छी योगा टीचर है अभिरामी आंटी,
Okay.
उनको बोले सिखाने के लिए, आप सीखोगे
हाँ।
योगा?
What subjects do you like in school, Viveka?
GK.
You like GK, then what else?
English.
You like English.
हाँ.
And she's also very good in math. No? You did 2 digit, single digit math, addition, subtraction that day with Shubha aunty you did. Only multiplication is a problem. That's why auntie said you should learn tables, no? That's an improvement. Single and 2 digit math that she told me. Good girl.
Side. Yeah, look up. Down. Look up.
Super.
Very good. That's it. Yeah. Close your eyes tightly, like that. Yeah. Do E. Show your teeth. Yeah. Okay. Fine. See, put your hands. Yeah.
Very good. Super.
Now turn it like this. Yeah. Close your eyes now. Yeah. Yeah. Now let us see how you walk. Come, walk. Walk up to there.
Very good.
Yeah, walk once more. Yeah.
Now, so,
Stand with your feet together. Feet together. Yeah. Yeah. Sit down. Viveka, touch your nose like this. Yeah. 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 3 times. Yeah.
Very good.
Good. Good. रूम में पेशेंट देख रही है, बुलाएगी, हाँ बाद में बुलाएगी। So that was a video. So she was actually munching on a biscuit when we were doing the video, but the movements are very similar when she's sitting in the waiting area. So we didn't use a hidden camera or something. So those are the kinds of movements where and she keeps muttering, and then when she's agitated, she's very abusive. That's in her mother tongue. When she's cooperative, this is the way she is. She's eating, she's very happy. But the movements are very similar to what we saw now. So physical examination was, she had a wide-based gait. The gait has improved now though. And those are the involuntary movements, the face, neck, shoulder, the tongue. So many of them have kind of plateaued the symptoms. The total count is still high, still 13,000. It's been the trend. Normocytic, normochromic, it's around 11.5, the hemoglobin. And the metabolic presently is at 250, and topirol and clozapine and vitamins. So it's not very consistent with Wilson's, but we put the symptoms together, and because we got, the liver-wise, she was all right, and the ultrasound of the abdomen and the CT chest, all that was fine, because her father was sick with TB. So, and the CSF was normal. So the dilemma came in, I think there was some kind of clarity because we had one positive test in terms of copper being high. So we thought Dr. ESK thought that could give her a trial of penicillamine, and we've seen that there are some improvements. So it appears to be a partial response. We don't know, it will take more time and what else we should be looking at. So that is the reason for presentation.